thank you very much for joining us tonight. This is a re-recording of a talk given earlier today in which there were some technical difficulties. We sincerely apologize for the pause in broadcast, and we're re-recording it for anybody that wishes to view this again. My talk is entitled COVID-19 Vaccination, Reasons Not to Be Scared. My name is Dr. Anuj Mehta. I'm an assistant professor of medicine at Denver Health and Hospital Authority with adjunct appointments at National Jewish Health and the University of Colorado. I also serve as the chair of the GERC Medical Advisory Group on Vaccine Allocation, and it's a pleasure to be here today. In terms of disclosures, I have no conflicts of interest. I do receive funding from the National Institutes of Health for unrelated research, but I have no financial disclosures related to vaccines. However, as I stated, I am the chair of the GERC Medical Advisory Group on Vaccine Allocation. I'm a member of the CDPHE Joint Vaccination Task Force, and I serve as one of CDPHE's vaccine champions. And so all of that does influence my view on vaccines. The objectives of this talk are actually quite broad to try and explain to people the process of COVID-19 vaccination. We're going to review a little bit about how immunity works at a high level of biology. We're going to discuss mRNA vaccines. What are they and should we trust them? What's the current data on safety and efficacy with some late breaking news from earlier today, and review who gets the vaccine first in Colorado. My job is not to convince you to get the vaccine, but to give you the information to make the best decision for yourself. So some basic biology about how immunity works. These green circles with some spikes on them represent any type of virus or bacteria that our bodies may encounter. When these enter our body, they have little spikes on them that represent proteins or sugars on the surface of the virus or bacteria that are unique to that virus. Over here in the blue circle is an immune cell that lives in our body. These are the cells that drive our immunity and protect us from infection. And the red fork sticking off of it is an antibody waiting to find something that matches its binding site, or namely that fork. So when a virus enters our body, these immune cells seek them out, and if the antibody matches one of the proteins on the virus, they'll bind together, join together, and then the immune cell will actually eat the virus and pull it inside itself with the antibody. This will start a chain reaction in which the immune cell recognizes that the antibody is effective against this foreign virus. And that cell then turns into a factory, churning out antibodies en masse, and those antibodies then go and attack the rest of the viruses. And through a complex process, this is how we engender immunity and fight off infection. The key concept is that your body makes antibodies against proteins, and in some cases sugar molecules, but today we're going to be discussing proteins mostly that belong to a virus or bacteria. So vaccines take advantage of this biology, and there are a lot of different types of vaccines that are used in clinical practice every single day. So the earliest forms, and many of which still exist, are live or attenuated. That means weak vaccines. This is where we take a virus or bacteria that's represented by the green circle here, and the spikes on the outside of the square are actually proteins that are unique to that virus or bacteria. So one way to build a vaccine is to weaken that virus or bacteria. It turns from an active virus or bacteria into a vaccine product because through whatever method, we weaken it so it can actually cause infection. And these little breaks in the square wall are actually a sign that this is a weakened virus that we're hoping doesn't cause infection and actually engenders immunity. Another way we can build some examples, are the MMR vaccine that children receive, nasal influenza vaccines. They're fairly rare, but some people do utilize them. Varicella or chickenpox vaccines all utilize live or weakened viruses to generate vaccines. Another way to engender immunity is to use an inactivated or killed virus or bacteria, so that we call those inactivated or killed vaccines. So again, the square represents a virus or bacteria that has proteins on it that are unique to that virus or bacteria, and we can kill them through a variety of ways, and then we inject that dead virus or bacteria into a person, and the proteins are still on the dead virus, and our immune system then reacts to those proteins. Another way that has been proposed to actually accomplish the same task is not to use the same virus or bacteria that causes illness, but to take a very different virus, like say the virus that causes the common cold, attach the bacteria from a virus like COVID to that to the cold virus and then kill that. And that's represented here, where the red square shows that it's actually a different virus or bacteria. So it's not utilizing the same one that causes infection, but nonetheless, we end up killing it, and then we inject that into the body. The proteins on this killed virus are actually the same as the original virus that we wanted to create immunity against. And this was an inactivated or killed vaccine. And some of those examples are common annual influenza shot, hepatitis A shots, or the polio shot. And then another approach to generating immunity is thinking, okay, if it's the protein that sits on the outside of a virus, why not just make a lot of that protein and inject the protein as opposed to either a live or dead virus or bacteria? And so that's exactly what some vaccines take advantage of. They create purified proteins or purified sugar molecules in some cases that are unique to a specific virus or bacteria, and then we inject them in the human body, and that's what generates immunity. And specifically, in this case, we're only injecting the protein, so there's no full virus or full bacteria that's being injected. Some examples of that are pneumonia, the pneumonia vaccines, the HPV vaccine, shingles vaccines, and hepatitis B. So as you can see, there are a variety of vaccine types that are out there that we use every single day in clinical practice, but they all actually are fairly common in how they induce immunity. We utilize either a live or dead virus to introduce a foreign protein, and our immune system reacts to that, or we make that foreign protein in the lab and inject that into the body, and that generates immunity. So I want to introduce you to the face of our enemy in this war that we've been fighting now for nearly 8 months. This is the SARS-CoV-2 virus, also known as COVID. And when we look at the virus, we can see that there are, similar to other viruses and bacteria, very unique proteins that sit on the surface of the virus. And in the case of COVID, the protein of interest that I'm going to be speaking a lot about is called the spike protein. The spike protein is the target of almost every single vaccine that's being developed. It's unique to the COVID virus, and it is something that allows us to think of a way to build a vaccine that is effective against the virus. The great thing about the spike protein is that the sequence or the structure of that protein and the code that allows it to be built was deciphered early in the pandemic, and that's actually what enabled us to be able to design vaccines so quickly. So we're going to return to a little bit of basic biology. This is the central dogma of biology, that DNA is converted into RNA, in this case messenger RNA, and that is then translated into a protein. Proteins are the fundamental building blocks of life. All of our cells are built out of proteins. All of the reactions like generating energy and building sugars in our body rely on proteins and enzymes. And so proteins are really important to day-to-day life. And conceptually what this means is that DNA is the blueprint for our body. When the blueprint gets converted into messenger, that's the M, messenger RNA in our cells, and that messenger RNA carries the code for a protein to a factory that lives in our cells. Every single one of our cells has very active factories that are solely designed to build proteins based on the code held in the mRNA. So the mRNA goes into the factory and out comes a protein, and the protein makes us. This idea of DNA to RNA to protein is the central dogma of biology. It is the driving force of life, everything from bacteria to human beings. And it is what we are going to take advantage of in developing a new class of vaccines. But this idea of RNA being the code that helps build proteins has actually led to RNA technologies that have been around for nearly 2 decades. For decades, we've been investigating RNA as a potential therapeutic for things like cancer and other types of diseases. And there have been some technological limitations, but RNA has been utilized in clinical trials for other diseases for several years now, and we have some safety data from those types of trials. So it's not entirely a new technology, but as I'll show you, the new part is how we actually get it into the body. So how do mRNA vaccines work? So as I said, mRNA is the code that goes between the DNA to the factories that make our proteins. It's the code that gets translated into a protein. So everything has mRNA, and you can just and we're actually really good in the lab of building mRNA molecules. We can actually sequence them really easily into a specific code, say to code for a protein like the spike protein. So if we just built the mRNA and injected it into a body, so what I call naked injections, the problem is that our bodies are really, really good at breaking down mRNA. It's something we've evolved as part of our immune system to prevent foreign RNA from entering our body. And so our body rapidly destroys it, and that's one of the reasons past attempts at utilizing RNA technology for healthcare have unfortunately failed. But these have gone to clinical trials, not for vaccines, but for other types of therapeutics, RNA technology, and they've been shown to be safe across a few different conditions. Unfortunately, they didn't reach their efficacy marks for different types of cancer. So the new technology around mRNA vaccines actually is less the RNA and actually the bubble in which it's wrapped. So in this case, we have mRNA that's wrapped in a blue bubble, and on the other side of the slide over here, we have a circle that represents the human cell. And it's very intentional that the color of the bubble and the color of the cell wall, the human cell wall, are the same. And what this is we've now developed technology, specifically Pfizer, BioNTech, Moderna, and other companies have developed technology to encapsulate the mRNA in a bubble that looks very similar to the structure of the human cell wall. And what does that allow us to accomplish? So because this wall looks very similar to the human cell wall, it is able to penetrate into the cell. Then once it's inside the cell, the bubble actually goes away. Now you have the mRNA in the cell, much like our own RNA that lives in our cell all the time. We have the factories that build proteins that typically, that always then take the RNA and convert it into proteins. The factories go to the mRNA and build proteins. Now, in the case of mRNA vaccines, the RNA carries the code for this foreign spike protein that is unique to the coronavirus. And what's really fantastic about this, it doesn't carry anything else. It only carries the code for this one single protein. It doesn't carry the code for any other part of the virus, and a single protein can't give you COVID. So our own protein building factories that live in our cells and make proteins billions of times a second every single day now have the code to make this very singular protein that is unique to the coronavirus, the spike protein. So the factories make this protein. The protein goes out to the cell where it can be exposed to the immune system. And then as we described in the first slide, the immune system then reacts to these foreign proteins, not to the human cell, but to the foreign proteins and develops immunity against that protein. The next time your body is likely to see that protein is actually if and when you're exposed to the coronavirus. And at that point, your body will then have knowledge about how to make antibodies to protect you. And that is the fundamental way in which mRNA vaccines are going to build immunity. I think what's really important to talk about, and what I think a lot of safety concerns revolve around, is what happens to this mRNA after it makes the protein. Well, as I said, the mRNA does not exist in the body for very long. Our bodies are exquisitely good at destroying RNA. Even our own RNA, we degrade over time. We don't want it hanging out once it's done its job. And so these mechanisms that live within our own bodies degrade the RNA that's part of the vaccine. We don't actually know how long this takes, but I suspect a few days to a week, and the RNA is gone. The other thing to really understand is that other things live in our cells. I didn't show a picture, but in this picture, we have the mRNA of the COVID spike protein, the mRNA from the vaccine, and we have our own DNA in the human cell. There is no way that this mRNA goes to affect the DNA. It cannot change your DNA, it is not gene therapy, and it doesn't get incorporated into your DNA. And as I stated, the mRNA segment actually gets degraded very quickly. So your DNA is intact and it's not affected by the vaccine. So I think the take-home messages about mRNA vaccines is you cannot get COVID from the vaccines. The mRNA vaccines encode a specific singular protein, the spike protein. It utilizes the same process of building immunity and preventing disease as other vaccines. Namely, it is trying to get a foreign protein into our body. Now, whether it's injected, whether that protein is made in the lab and injected into our body, or whether we utilize our body's own factories, protein building factories to build it, that's the difference. So the delivery method is actually the difference. That's the mRNA. And our bodies are very efficient at making protein out of mRNA, so this tends to be actually a relatively rapid onset of immunity. It's important to realize that RNA-based technologies have been around for a long time. The novel aspect of this is the delivery mechanism. mRNA does not affect DNA in the form of an mRNA vaccine. mRNA is rapidly destroyed after it's injected into the human body, and the whole point of testing clinical trials is, can we inject it, have it induce immunity before it gets degraded? It's also interesting to note, as I stated, that generating purified protein, if we wanted to just inject spike protein made in the lab, actually is quite difficult. It takes a long time to manufacture those types of quantities. Our bodies are actually better at building proteins than manufacturing plants built by pharmaceutical companies. So it's easier to manufacture large quantities of mRNA vaccines quickly compared to some other vaccines, not all, but some. With all of those theoretical underpinnings, we should still look at each individual vaccine that's up for approval or authorization for safety and efficacy data. So what's the data so far? And I'm going to also leave you with some late-breaking news from just a few hours ago. There are 3 leading candidates for vaccines in the United States. There's the Pfizer-BioNTech, the mRNA-based vaccine that's given in 2 doses 21 days apart, the Moderna mRNA vaccine given 28 days apart, and the AstraZeneca vaccine, which is an inactivated adenovirus that's been implanted with a spike protein. Adenovirus is the virus that causes the common cold, so it's inactivated, but it also carries a spike protein, and that's 28 days apart. And as I said, the spike protein for the AstraZeneca is artificially injected on the virus. The spike protein is in nature unique to the coronavirus. So let's talk about the one that we know the most data about, the Pfizer-BioNTech mRNA vaccine. So this was a very large phase 2, phase 3 clinical trial in which over 40,000 participants were recruited. These were volunteers from multiple countries, and I'll eventually show you from very diverse backgrounds. And in most clinical trials, and similar to this one, about half got the vaccine and half got a placebo. That's a saltwater injection. And amongst those that got either treatment, 9 who got the vaccine got sick. 6 were between the ages of 16 and 55, and 3 were over the age of 55. In the group that got placebo or a saltwater injection, 169 people got sick, 120 were aged 16 to 55, and 49 were over the age of 55. Now, while these may seem like relatively small numbers, this is how all vaccine trials work. We are not exposing the participants to coronavirus. They're encountering it in their day-to-day activity, so we don't expect large numbers of people to get sick. But the threshold for actually saying the vaccine is effective is that enough people have to get sick. So this is pretty standard. This is the same process that other vaccines have gone through. And what's also important is that there was a difference in the number of severe cases between those who got the vaccine versus those who got the placebo or saltwater injection. And this is where the estimates come from. The 9 versus 169 people that got sick shows 95% efficacy for the Pfizer vaccine after 2 doses. And in terms of severe cases, it was about 89% efficacy. Now, the reason I use 89%-ish is the fact that this is still just 10 cases. And so we'll need to see larger numbers to actually understand what the true efficacy is at preventing severe disease. But there's convincing data that it is both it has efficacy at preventing COVID illness, you from getting sick with COVID, and preventing severe disease. This is a little bit of a busy slide, and this is where we present some of the side effects. So every medication has side effects, whether it's Tylenol, ibuprofen, to the flu vaccine, to now COVID vaccines. So that's nothing unique to have side effects. The trials were actually very interesting. Of the 40,000 people, they selected a small subgroup of people in which they engaged with them every single day to see if they were having side effects. So sometimes that was through phone calls, and sometimes that was through this small subgroup of participants logging in a diary on their smartphone. And so when you are actively asked about side effects, you're more likely to report them. So these are called solicited side effects. And the rates are actually quite high. And so what we see is the rates after dose 1 and dose 2 broken down by age categories of 18 to 55 and those over the age of 55. And what we have in the black numbers is the overall rate. So right under fatigue, 47.4% of all people had any type of fatigue. What's in red is actually the rate of severe fatigue that significantly impacted somebody's day-to-day life. And so what we can see is there was injection site pain. It's a shot, it hurts. That there were some significant rates of fever after the first dose, about 3.7% for those between the ages of 18 to 55, and even less for those over the age of 55, 1.4%. But the rate of having a fever actually goes up significantly in second dose, likely because we're inducing a longer immunity, a larger and stronger immune response. So fever, fatigue, headache, chills, muscle pains, joint pains, these are the same side effects of the flu vaccine and most other vaccines. A lot of times people will say, I got a vaccine and I got sick. It gave me the flu. There's no way the flu vaccine gives people the flu because it's not an active or live virus. Similarly, there is no way the coronavirus vaccines, specifically the mRNA vaccine or even the AstraZeneca vaccine, can give you COVID. What these symptoms are is a sign of your immune system becoming active. And this is a good sign. It means the vaccine's working. It's actually something that gave some people some insight as to whether they got the placebo or the actual vaccine in the randomized clinical trial. And so fever, fatigue, headache, chills, muscle pain, these are the expected side effects of anything that activates your immune system. So the numbers might be a little bit scary. Oh, almost half of them had fatigue after the first dose, or 21% had muscle pain. But I would draw your eyes to the red numbers, the rates of severe side effects, which were actually quite low. And remind yourself that this is the group of people that were actively called or put enter diary information every single day, who were required to report side effects every single day. This slide actually tells us what the overall side effect was from everybody who had to call in. So these weren't solicited. These were people calling up and saying, hey, I'm experiencing this. Is this normal? Otherwise, they wouldn't call in if they didn't have that side effect. And we also know that the threshold to call in for a lot of people is relatively high. So we expect lower rates. And what we're seeing here is that across both doses, in the 2 months from the first dose to second dose, so 21 days in between and then 1 month after the second dose, only 6% actually called in complaining of a fever. Only 11% actually called in and said, my arm hurts. Now, we know that more people's arm hurts, so the real side effect rate is somewhere in between what was on the slide before and what's actually reported here. Similarly, muscle and joint pains, a lot lower when people had to call in to complain about it. And same thing with headache. And I think this actually probably reflects more likely what people are going to experience in terms of how it affects their day-to-day work life if they get the vaccine around the time of their next shift. So there are side effects. Side effects are totally normal. They happen with every vaccine, and they are the exact same side effects of your immune system activating: fever, chills, pain, muscle aches, and arthralgias. But that the real rates are probably not as high as reported on the previous slide. But there's something that we need to plan about, because sometimes these are the symptoms that can mimic COVID. But again, the vaccine cannot cause COVID. Now, I know there's been some concerns about allergic reactions. Yesterday, there were multiple media reports about 2 nurses in the UK that received the vaccine and had allergic reactions. First of all, what's important is that both nurses are doing well. Both nurses had a history of severe allergies of anaphylactoid reactions. That's where you start feeling short of breath and your throat's closing up. And what we also know is that anything you put in your body can cause an allergy, whether it's a medication, a food, a foreign substance. That's why all the medication ads on television always say, if you're allergic to this medication, don't take it, because anything can cause an allergy. Allergic reactions are nothing new in the world of medicine. The confusing thing is that what's in the vial for the mRNA vaccines is just the mRNA. Flu vaccines and other vaccines have preservative, have other stabilizing chemicals. What's in these vials is actually just the mRNA suspended in a liquid. And so it's harder to know what was inducing the allergic reaction, which is why everybody's having some degree of caution. The reality of the data is that in the clinical trial, 0.6% of people in the vaccine arm had an allergic reaction of some type, typically itching, hypersensitivity, compared to 0.5% in the placebo arm, the people that didn't even get the vaccine. So we know that people have these reactions even when they don't get an active drug. We are still looking for advice. There was some discussion at the FDA meeting today about this, but no firm recommendations. My gestalt impression is that allergic reactions are an everyday part of vaccines. And I don't, based on the data, think that they're any more likely for a coronavirus vaccine compared to a different vaccine. With that being said, if you've had an allergic reaction to a vaccine before, maybe wait for some more data. Similarly, if you've ever had a severe anaphylactoid reaction where your throat's closing, maybe wait for more data. But if you have a food allergy or medication allergy to like penicillin or sulfa, where you get a little itchy, you may get a few hives, and that's about it, you know, that's not, this allergic reaction concern, it should not be something that prevents you from getting vaccinated. Furthermore, these were easily treatable conditions, and that's why medical professionals are the ones giving the vaccine. Moving on to Moderna, we have a lot less data about Moderna. I'm hoping we get more next week before the FDA meets to discuss the Moderna vaccine. But in that trial, there were about 30,000 participants, again, broken up into 15,000 that got the vaccine, 15,000 that got the placebo or saltwater injection. 11 got sick out of the 15,000 that got the vaccine versus 185 got sick out of the 15,000 that received a placebo, which is also a pretty stark difference. And there was a big difference in the number of severe cases, 30 severe cases in those that got the placebo compared to 0. And that leads to these types of efficacy statements, that 94% efficacy for the Moderna vaccine. That's comparing this. And again, 11 versus 185. This is the exact way previous clinical trials have been conducted. We are not challenging people with the coronavirus, so the numbers are going to be small. They report 100%-ish. They say 100%. The company, I say 100%-ish, because we'll see what the real numbers are as we see more people getting the vaccine. The side effects were very similar. They don't report on fever, but injection site pain, fatigue, myalgias, arthralgias. This is pretty limited data. The Pfizer data, the FDA released 50 pages of safety data a couple of days ago because it was reviewed today by the FDA for emergency use authorization. And I suspect that they'll release similar data before the meeting to discuss the Moderna vaccine next week. So I anticipate that we'll have a lot more detail about side effects for the Moderna vaccine next week. A big question is who was in the trials. A lot of people always say, well, how do I know it's going to work for me? Were people like me or people who look like me in the trials? I have to commend the pharmaceutical companies, and I don't do that often, but I do think that there was an active plan to try and ensure a diverse population. We know through history that there's a great deal of mistrust amongst communities of color for medical research, and thus it's harder to recruit them to participate in research. So clinical trials in the past have not represented the general U.S. population. There are fewer women in clinical trials, there are fewer black individuals, and there are fewer Hispanic or Latinx individuals and fewer Native Americans in these types of clinical trials. This is not the case with the mRNA vaccine studies. So in the Pfizer-BioNTech trial, almost half were female, 49.4%. A quarter were over the age of 65. 26% identified as Hispanic. 9.8% identified as Black. And there were 46% of people that had any type of comorbidity, but specifically the ones that we are concerned about, 35% of individuals had obesity. 8.4% had diabetes, 8% had lung disease. And so what we see is that the population involved in the clinical trial does tend to reflect the more general population. And that gives us greater confidence that this vaccine is going to be effective across age and genders, which I'll get to in a second. The Moderna trial doesn't have as much data out yet, but about half of the participants were female. There were more than 23% were over the age of 65, so are older, more vulnerable adults. More than 20% identified as Hispanic and more than 10% self-identified as Black. At least 17% of people within the age of 18 to 65 had some type of comorbidity. A quarter had obesity, and of those with comorbidities, 36% of them had diabetes. So again, we're seeing that these populations for both of the mRNA vaccine trials were diverse based on age, gender, race, ethnicity, and comorbidities. And through multiple analyses, the Pfizer data we have through the release from the FDA yesterday from an independent body we'll hopefully get the same data from Moderna, but what we know from the Pfizer data is that there was no difference in efficacy across age, race, gender, or chronic disease status. There was no difference in efficacy, and there was no difference in safety. And I think those are the two big concepts for people that are hesitant out of concern that the people in the clinical trial don't look like them. Moderna has made the statement that there was no difference, and we're waiting to see what the data shows when they release theirs, hopefully again next week. But the Pfizer data, I think, is pretty convincing that there was no difference across these very important groups to consider, specifically age, race, ethnicity, gender, and chronic disease status. I'm going to spend a lot less time talking about the AstraZeneca Oxford vaccine. So it's an inactivated adeno cold virus with the spike protein on the surface. So this was engineered. The cold virus doesn't typically have the spike protein, doesn't ever have the spike protein in nature. And so in a lab, they put the spike protein on top of this virus. We know that, the cold virus were really good at inactivating or killing. So it was a good vector. So the vaccine means we're injecting a dead cold virus that's been engineered to have the spike protein kind of stapled onto its surface. These types of vaccines are much easier to manufacture and store. They have a 6-month room temperature shelf life, which is fantastic when you start thinking about global health. So we only have interim results, and some of the confusion is about the fact that there were 2 different dosing regimens that were not intentional. It was a manufacturing mistake. So there was the half dose followed by a full dose 28 days later that showed 90% efficacy. And then there was the full dose followed by the full dose, which only showed 62% efficacy with a pooled result of 70.4%. So there are some problems. Obviously, the dosing regimens were not pre-planned approach. Nobody's fully been able to explain why a half dose up front actually led to greater protection. There were a lot fewer people that got this half dose, full dose combination. And then the results are actually pooled across multiple different clinical trials in different countries that had slightly different protocols. So the bottom line for AstraZeneca and Oxford, we'll need more data and time. And so I don't anticipate the FDA considering this vaccine for some time, several months at least. I think a lot of people, when we start thinking about the process, we ask ourselves, is it too fast? So what I can say after reviewing a lot of the data and being part of the conversation for some time is the process and trial designs are similar to vaccine trials from the past. And I use an analogy. If you imagine in, say, Denver, the goal is to build skyscrapers, and we have different construction companies that are building skyscrapers. On this slide, we have 4 different companies with blueprints of very similar buildings, and they want to build a skyscraper. Well, it may take each of them 2 years. But if there is a concerted effort and all construction companies, even new ones, are recruited to build this, put up this building together at the same time, and all resources are poured into it, you might be able to do it in 6 months. And while that's not the only reason we've been able to generate these new vaccines so quickly, I will say that at the level of pharmaceutical companies and researchers, I've never seen a situation where so many people have been working on a single problem so hard. So almost all of our pharmaceutical efforts, so much of the scientific community, the NIH and other organizations around the country and the world have been working towards developing a vaccine. And with that many resources, that much money, that much person power behind it, you can imagine that it's going to have a far accelerated time frame. That doesn't necessarily mean that it's any less safe or less effective. I also think that the speed of the trials, once they were launched, was dictated heavily by how fast COVID was spreading in the community. And as I said, the endpoint was the number of people that got COVID. And so as we've seen in the last month to 2 months, we've had a big uptick in the spread in a lot of communities, and that led to them reaching their endpoint faster. It's not a good thing that people got COVID, but it's a good thing from the perspective of the clinical trials that they were able to reach their endpoint a little bit faster. So in terms of the process, this idea of emergency use authorizations has been floated around a lot. So what are they? They were developed primarily for response to biologic, chemical, and radiologic attacks. They were aimed to deploy specific treatments that didn't have full approval, but that had some evidence of safety and benefit when no other options existed. They were, as I stated, not the equivalent of full approval. They required ongoing follow-up. And what we know now during the pandemic is that it's had a complex history during the COVID-19 pandemic. But vaccines in general have 2 additional checkpoints. So the regulatory approach is governed by the Food and Drug Administration that actually gives authorization or approval and the authorization would be through that EUA mechanism, emergency use authorization, or the CDC, and the CDC, who offers recommendations about who should get the vaccine or any vaccine. So these two groups actually have very strong independent organizations that operate under them. So in the Food and Drug Administration, there's the Vaccines and Related Biological Products Advisory Committee, the VRB-PAC, and I have to remind myself of that acronym every time I say it, that advises the FDA. This is a group of independent scientists and public health experts. They do not work for the FDA. Most of them are senior faculty members at various well-known universities and institutions, or senior public health officials. So these are independent people that scrutinize the data. The VRB-PAC actually met today to discuss the Pfizer vaccine and actually asked the company and FDA officials 8 hours worth of questions about safety and efficacy. Under the CDC, there's the Advisory Committee on Immunization Practices, or ACIP, and that is the body that offers all vaccine recommendations for everything in the country, essentially. When kids should get the MMR vaccine, when they should get the chickenpox vaccine, when adults should get the pneumonia vaccine. And they will offer recommendations about who should get the vaccine first and when that should be. What I can say, and very proudly and happily say, is that the VRB-PAC actually met today to discuss the Pfizer vaccine and voted in favor of an emergency use authorization. So that vote will go back to the FDA, who typically follows their lead. They will either offer an authorization or not. I anticipate it will be sometime this weekend, maybe Saturday or Sunday. And very quickly, ACIP will meet to discuss and offer recommendations about who should get the vaccine now that it's authorized. And so these two independent groups is the VRB-PAC and ACIP. ACIP is also an independent group staffed by really well-known scientists and public health officials. Gives me a lot of confidence that this is not being driven by the government alone, that this is driven by great scientists doing really good science. In terms of who gets the vaccine first, Governor Polis, for Colorado specifically, Governor Polis released a new phased implementation plan. And this is basically the concept that we're not going to have enough to vaccinate everybody that needs it on day one. Phase one, which I'm going to focus on the most, is actually high-risk healthcare workers and long-term care facility and staff, the individuals that have the highest risk of mortality, followed by moderate-risk healthcare workers. And there's some definitions of this behind the scene, and we can get into this in greater detail. What I will say is that this plan will also potentially be modified as the Advisory Committee on Immunization Practices offers ongoing guidance. And again, this is hot off the press, just released yesterday as an update to the previous guidelines that I helped draft. I think it's really important to remember that vaccines are not a free ticket. So these trials were designed to detect COVID illness. So they designed to detect people that got sick from COVID. We know that asymptomatic infection is a major driver of disease spread in the community, and that was not an endpoint within these clinical trials. Now, logically, it makes sense. If you're decreasing the rate of symptomatic infection, you probably are decreasing the rate of asymptomatic infection to a certain degree. But since we don't know that yet entirely, it's really important to still wear a mask. That's to protect you. It's because we know that's not 100% efficacy, but also to protect your friends and family in case you happen to nonetheless be an asymptomatic spreader, especially before you get your second dose. We also still need to social distance, and that is a fundamental tenet of public health right now. It's really important, mask wearing and social distancing, until we know more about asymptomatic spread. As more and more people get vaccinated, we will be able to slowly start to go back to some semblance of normal, but that's going to take some time. So my major conclusions and take-home points are that you cannot get COVID from the vaccines. RNA technology has been around for a long time. The mRNA vaccine does not affect your DNA. It's not gene therapy. The mRNA vaccines induce immunity in the same way as other vaccines that have been around for a long time, so long-term side effects are less concerning on a theoretical basis. The Pfizer and Moderna vaccines have high efficacy. We know a lot about side effects, and they're similar to other vaccines: fever, aches, fatigue, chills. We know the most about the Pfizer vaccine that was voted, that the VRB-PAC voted in favor of today, And the rates of those are still a little bit nebulous, but we know that they're there, and you should anticipate side effects. That's true of every single medication. That's a sign that your immune system is working, but it is not a sign that you are getting COVID from the vaccine. And lastly, and this inspires a lot of confidence in me, is that there are these really well-respected independent experts reviewing the data. And that really drives a lot of my confidence. I've obviously reviewed the data in depth myself, and I have a lot of faith in the safety and efficacy of the Pfizer vaccine, and we're still waiting to see what Moderna releases in totality from their clinical trial. But I anticipate having a very similar feeling. But that being said, the best proof is in the pudding. And based on the data from the Pfizer vaccine, I will be proud to get the vaccine at Denver Health as soon as my name is called. My wife is a healthcare provider. She's a primary care provider at the nurse practitioner at the Montbello Clinic. It's one of Denver Health satellite clinics. And she too will be vaccinated. I asked her this morning as soon as her name is called. And so we're very excited about what these vaccines can do to try and return us to some semblance of normality. I think that this pandemic, the last 8 months, has been a very long and hard-fought battle that we continue to fight, and we're facing, even with vaccines, a dark winter. I was in the ICU up until Tuesday at Denver Health, and that's where I spend my clinical time, and my colleagues, both physicians, APPs, nurses, respiratory therapists, environmental services, the food technicians, patient transporters, they're all tired, they're all afraid, but they all show up to work every day dedicated to the idea that we can help people. And they truly inspire me to do all the work that I do now. And so what I say to them is that we will get through this together, that all of you are heroes, that you matter, and you are making a difference in this world. So there is a light at the end of the tunnel, and I think the vaccines are going to be part of us getting there. So during the original talk this morning, we fielded a lot of questions, and I tried to group them into big categories, and I'm going to try and answer them now, knowing full well that I may not get to everything that was talked about earlier today. So there were a lot of questions about pregnant women, breastfeeding mothers, and minors. And what I can say is that pregnant women were not included in any of the clinical trials. That's pretty standard. These are slightly higher risk individuals that you don't necessarily want to start an experimental therapy on. So we will wait for recommendations from the FDA and from ACIP on pregnant women, and we will look to the letter of the EUA. As of now, we have no data, so we have not, in terms of recommendations for a phased approach, added them to any of the phases. Once we have data, we will advocate for them. Breastfeeding mothers, very similar. We don't have a lot of data. I'm not entirely sure if they were included in the clinical trial, but we're waiting for federal guidance. And the last thing is minors. So the Pfizer trial included people down to the age of 16, but 16 and 17-year-olds were actually a very small number. And that was actually something that was hotly debated at the FDA meeting earlier today. And individuals down to the age of 12 were included in the Pfizer trial, but only in about the last month. So we have zero data on children, essentially. It is not common to include children in clinical trials up front because you want to demonstrate safety in adults first. So until we have more data or at least federal recommendations, minors are also not part of the phased implementation plan, but we fully recognize that they will be added in the future. There were a lot of questions about the duration of immunity, and unfortunately, we just don't know. So, one of the downsides of being faster doesn't mean it's bad. We were faster because we had all the resources in building out this amazing pathway. We also was faster because the RNA technology already existed. We just needed to develop that new bubble. But one of the downsides of the speed is that we have not been able to see how long that immunity will last. I think as of now, there's pretty robust data that there should be an ongoing immune response up to 6 months. And I think theoretically, it makes sense that we'll have a much longer base of immunity, but we need to wait to see what the data shows. Earlier today, there were a lot of questions about autoimmune conditions. So specifically, when you activate the immune system to attack a protein, might it then go on attacking proteins that belong to you? So normal human proteins. That's a fundamental concern with every vaccine that operates along the basic concepts that we talked about. Specifically, if you induce an immune response and build antibodies to anything foreign, if anything in your body looks like that foreign particle, it's a possibility. There were no reports of severe autoimmune conditions in either clinical trial as of yet. Well, I think it's maybe something to consider if you already have an autoimmune condition. It probably shouldn't make you stop. It's a discussion worth having with your doctor, and we need to have some more data. But, theoretically, I don't think it's likely to cause autoimmune conditions that are new in any different way than other vaccines. There were a lot of questions about what happens to the mRNA. So as I said, it gets degraded very quickly, can't detect it in the body, even if we tried. There were some questions about storage capacity and what that means for implementation issues. So, the Pfizer vaccine does require negative 80-degree storage. And that's going to be how you achieve long-term storage. You can repack the boxes with dry ice to extend that thermal shipper. But once it's taken out at negative 80 degrees, a lot of other things can happen. So what's good about Pfizer, and what most people don't talk about, is that if it's taken out in the undiluted form, you can actually store it at regular freezer temperatures for about 5 days. So that adds to the shelf life in clinics that may not have a negative 80-degree freezer. There was a specific question about, given the ultra-low cold storage chain issues, are we concerned that in transport, some of the boxes may warm up and could inactivate the vaccine? What I think is really fascinating that Pfizer has done is that the boxes of vaccine, carry a tracker on them. It's a little bit more complicated than a UPS tracking code. It's actually a computer chip that sits on the physical box that both gives their command center situational knowledge of where every vaccine box is to prevent theft, but then also is a constant and continuous temperature tracker. So they can actually detect an alarm if any box exceeds its temperature allowance, and that will potentially trigger some quality assurance measures. So I think that's really, really cool. I just got a tile device for my keys because I keep on losing them. So this seems to be, like a tile on steroids with a thermometer attached to it. So that's really exciting to be able to track the boxes of vaccines. There are no trackers on the vials of vaccines. It's actually just the box, the thermal shipper. The Moderna vaccine actually is a little bit more forgiving. It can be stored at regular temperatures in a freezer, not a negative 80-degree freezer, for up to 30 days, and then has a 12-hour room temperature half-life. So that may actually allow us, if it receives an EUA as well, it may actually allow us to target more rural places that don't have negative 80-degree freezers with the Moderna vaccine. And as we saw, the efficacy is very, very similar. So I don't think anybody's getting shortchanged in that. Those were the majority of questions that I think people asked during the talk today. I emphasized during the talk today that it's really important to continue wearing masks and socially distancing. Those core public health measures are part of a big conglomerate of interventions, vaccines being only one part, mask wearing being another part, and social distancing, all of which will work together to try and end this pandemic. So with that, I want to thank everybody for their time here today. If you have any questions, you can contact me. If there are any questions that I didn't address, I appreciate everybody's patience who was on the phone or on the call earlier today with our technical difficulties. And this cast will be available through a private YouTube link to anybody that wants to view it to kind of get the full continuous stream without the interruptions, the technological interruptions. I also want to offer some very significant thanks to my wife. Again, she's a nurse practitioner at Montbello, and she looked at all my slides to make sure that the animations and everything made sense and that they would make sense to the readers. So I really thank her for being part of this and being a constant soundboard. Thank you to everyone, and be safe, be well, and I think there's a light at the end of the tunnel, so thank you.